All right, chapter 26, abdominal emergencies. We are going to cover a whole bunch of fun stuff, but abdominal anatomy and physiology. All right. The abdomen contains many organs from several different body systems, can cause confusion when determining the cause of abdominal emergencies. Thorough patient assessment is key. Specific diagnosis may not be necessary. Treatment is the same for most conditions. That's one thing important to remember, is that you might spend a lot of time doing a thorough and patient assessment, but most of the time there's only a few things that we in EMS in the field can do. So keep that in mind. In your abdomen, the region between the diaphragm and your pelvis, so that's what we consider the abdomen region. It contains many organs that provide the following function, which is going to be digestive, reproductive, endocrine, and regulatory. So in that space, we have all of those. So obviously, if you're in the upper part of the abdomen, you probably aren't going to be dealing with the reproductive system. So it kind of helps guide, but knowing those internal organs is key. And in this video, or in this slide, you can see some of the different organs where they're located at. And, you know, knowing the location, like we had talked about, I think a couple chapters ago, is going to make this job a lot easier. So when we divide it into quadrants, which we've talked about this in the past, we have the right upper quadrant, lower upper quadrant, right lower, and left lower. So used to describe and identify areas of pain. And when we do this, we talk about tenderness, discomfort, injury, and other abnormalities. So some of those abnormalities can be swelling, decoloration, where it's hard. So you have different things used to describe it, but there's our 4 quadrants. Your organs of your abdomen. We have our peritoneum, which is the thin membrane lining the abdominal cavity and covering each organ. Your parietal peritoneum, which is attached to the abdominal wall. And then the visceral peritoneum, which covers each organ. So understanding those differences, the peritoneum is the thin membrane lining the abdominal cavity, covering each organ. The parietal is attached to the abdominal wall, and the visceral covers each organ. So most enclosed within the organs of the abdomen, most are enclosed within the parietal peritoneum. A few lie in extraparietal space, which is outside of the peritoneum. There we have kidneys, pancreas, part of the aorta lie in the retroperitoneal space behind the peritoneum. The bladder and part of the rectum lie inferior to the peritoneum, so down below it. All right, so in females, we have reproductive organs and structures that lie within the abdomen and pelvis. There you've got ovaries, that's what that word is, fallopian tubes, and the uterus. We also have large blood vessels, including the aorta, inferior vena cava, hepatic artery, splenic artery, iliac artery, and the vein. Here's another side view, the cross section of the torso, with the view from the right. So know that slide, you probably have one in your book as well. So good thing to look at, and then know where you're located at in there. Next, we're going to talk about pain and discomfort, the fun part. So visceral pain originates from the organs within the abdomen. Few nerve endings allow for only diffuse sensation of pain. So that's one of those things where it's hard to tell, if your arm hurts, you know where your arm hurts, but in your abdomen it gets a little different. So usually pains in the abdomen are described as dull or achy. Intermittent, crampy, and colicky pain may result from hollow organs. Persistent or constant pain often originates from solid organs. So learning those two differences when you have in your NREMT or even in the field, if they're describing a crampy sensation, it's probably coming from a hollow organ. If they're describing a constant pain that doesn't go away, it stays there, it's probably coming from a solid organ. So knowing it for your NREMT for questions and then also knowing it in the field are two very easy ways to kind of help narrowing down what we have. All right, parietal pain originates from the parietal peritoneum. Many nerve endings allow for pain that is easier to locate and describe. Frequently described as sharp, pain is often constant and localized to a specific area. Tearing pain, not the most common type of abdominal pain, originates in the aorta or stomach. Separation of layers of aorta caused by an aneurysm. Retroperitoneal location of aorta causes pain to be referred to the back. Ulcers in the stomach can also cause a tearing pain. So if you get called, and that's the way somebody describes a tearing pain, especially in their back, you're going to want to be moving fast, because obviously diesel therapy is one of the few things we can do for an aortic aneurysm. So that is one of those things where it's just not a good. If you have that feeling, we are going to do as much as we can, but driving fast is about the best thing we can do. Referred pain, so perception of pain in skin or muscles at distant location. Your abdomen has many nerves from different parts of the nervous systems. Nerve pathways overlap as they return to the spinal cord. Pain sensation is transmitted from one system to another. So your abdomen is one of those locations where we get a lot of referred pains to. And sometimes they make absolutely no sense when you're on a call when somebody's describing their pains. And then after you end up talking to the hospital and they figure out what's going on, you're like, well, that they weren't describing that at all, but that's about the only thing you can get. All right, abdominal conditions. Appendicitis, which is an infection of the appendix. Signs and symptoms include nausea and sometimes vomiting. Pain often initially referred to umbilical region, followed by persistent right lower quadrant pain. A ruptured appendix is a sudden and severe increase in pain. Contents release into the abdomen, causes severe peritonitis. So if you have that and you think you have it, if you're transporting somebody or you're on scene and somebody thinks you think they have appendicitis, and all of a sudden it changes, what it's been described to me as from somebody that had it happen was their pain went from like a 5 or 6, they weren't very comfortable, and then all of a sudden it was like a 10. And so it went from, like it was sucked, it wasn't good, they were in a lot of pain, but it got unbearable, and it was in seconds that they went from here to here. So, peritonitis, which is irritation of the peritoneum, usually caused by foreign material in peritoneal space. Parietal peritoneum is sensitivity, especially to acidic substances. Irritation causes involuntary contractions of abdominal muscles. And signs and symptoms is abdominal pain and rigidity. So when you push on somebody and their stomach doesn't go in, that's when we got rigidity. All right, so cholelocystis and gallstones. Inflammation of the gallbladder, often caused by blockage of bile flow by gallstones. Symptoms often worsen by ingestion of fatty foods. Signs and symptoms, right upper quadrant or epigastric pain. Pain often referred to the shoulder. So when people have gallstones, it's weird. We had talked about how pain differs out. This is one of those where a lot of times it's pain in the shoulder, which, like I said, makes absolutely no sense. All right, pancreatitis, inflammation of the pancreas, common in patients with chronic alcohol abuse. Signs and symptoms includes epigastric pain, often referred to lower back or shoulder. Weirdly enough, there was a bunch of this going around a few years ago, which was kind of weird in our small community. There was 4 or 5 people I knew that had pancreatitis at the same time. 2 of them drank occasionally, but they weren't even hard drinkers. It's just something they ended up developing. But this is one of those things where a scene size up, if somebody's got alcohol bottles laying around everywhere and stuff like that, you know, and they're referring or saying some of these pains, this is what they're having, this is what's going on, you know, we're passing that information along to the hospital can be helpful. All right, gastrointestinal bleed, also known as a GI bleed. So bleeding within the GI tract from esophagus to rectum, so that whole entire space, anywhere you're bleeding is considered a GI bleed. May be minor to severe. The blood eventually exits either out of the mouth or rectum. It is often painless. And gastric ulcers, which are holes in the GI system from highly acidic gastric juices, can cause severe pain and peritonitis. So if you are ever in a call with a GI bleed, you will know. So signs and symptoms: dark colored stool, maroon or black, often tarry. Frank blood in the rectum. So when you actually see red blood coming out. Vomiting is coffee ground appearance, or vomiting of frank blood. So the difference is it an active bleed? Is it up here in your esophagus? And so you'll oftentimes just get frank blood if they throw up. If it's lower and they're throwing up, it's coffee grounds, it's probably a lower bleed, but it's still a GI bleed. And pain can be absent to severe, so it ranges everywhere in there. Not everyone's the same, not every bleed's the same. So you have a wide range in there as far as pain goes. Abdominal aortic aneurysm. It's a ballooning or weakening of the inner wall of the aorta. It tears and separates from outer layers, also known as a dissection. Weakened vessel bulges may continue to grow, and it may eventually rupture, which is a real bad day. All right, so signs and symptoms. Progressive, often sharp or tearing abdominal pain. Frequently radiates to the back. A rupture causes a rapid onset of excruciating abdominal and back pain. Signs of shock usually present, and then possible unequal in pedal pulses. So it's one of those things where if you have that, it's one of the things you check for. Now we're going to talk about good old hernias. That's a hole in the muscle layer of the abdominal wall, allowing tissue or parts of organs, commonly intestines, to protrude up against the skin. May be precipitated by heavy lifting. May cause strangulation of tissue or bowel obstruction. Requires transport to hospital for evaluation. So it's one thing if you have somebody with a hernia, you really want to encourage them to go to the hospital so you can get checked out. All right, so signs and symptoms. Sudden onset of abdominal pain, often following lifting. Palpable mass or lump in abdominal wall or crease of groin. And it's definitely noticeable when somebody has that. Weirdly enough, in the groin too. I know it seems weird, but renal colic. Severe flank pain caused by kidney stones traveling down the ureter. Signs and symptoms: severe pain in the flank or back. Frequently radiates to groin, often causes nausea and vomiting. Cardiac involvement. So pain from a myocardial infarction may be felt as abdominal discomfort. Includes epigastric pain, indigestion, or digestive discomfort. Always consider the possibility of a cardiac emergency as a cause of abdominal symptoms. All right, abdominal pain associated with the female reproductive system. Most serious cause is ectopic pregnancy. Occurs when fertilized embryo implants outside the uterus. Rupture can cause life-threatening internal bleeding. All right, so assessment and care of abdominal pain or discomfort. All right, many potential causes of abdominal pain. Role of EMT is not to diagnose. We focus our efforts on perform a thorough secondary assessment and identify serious or life-threatening conditions. Scene size up. Protect yourself from vomiting. Be aware of odors. Determine if patient's condition is medical, trauma, or both. And you can get both. You can have somebody fall, causes something to rupture, causes a bleed, So you could have a trauma that now is leading to a medical situation. Sometimes it can be days, weeks later, but that is our job. So primary assessment, you have your general impression, the level of consciousness and airway care, early signs of shock, the position of patient, consider application of supplemental oxygen to any hypoxic abdominal patient or in any situation where an oxygen saturation is deemed to be inaccurate. Onset. When did it begin and what were you doing? That's where we start talking about those hernias. Provocation or palpation. What makes it better or worse? Movement and position. And then quality. Describe the sensation. So all of those things, which is all part of our OPQRST, right? It's usually where we get those answers at, is what we need to make sure we're covering. We have our radiation, the point to its location, does it radiate or move? Severity, how bad is it on a pain scale of 0 to 10? And then time, how long have you had the pain or discomfort and has it changed? If you get called at 2 a.m. for somebody who has had this pain and they tell you they've had it for a week, the biggest question is what changed to make you call me now? And so they might have went from, well, it's been a dull, achy pain that's been like a little discomfort, maybe a 2 or 3, and now it's at a 10. So what changed to make you call me tonight? All right, history specific to female patients. Where are you in your menstrual cycle? Is your period late? Do you have bleeding from vagina that is not menstrual bleeding? If you are menstruating, is your flow normal? Also, have you had this pain before? If so, when did it happen and what was it like? Is it possible you are pregnant? And are you using birth control? So those are all important things to ask female patients, specifically of baby rearing years. To go ask an 80-year-old some of them questions is going to make you look like an idiot. But past medical history, we always want to know allergies, medications, pertinent past history, last oral intake, and events leading to the emergency. A geriatric note, decreased ability to perceive pain, more serious causes of abdominal pain and more likely to be life-threatening, may be complicated by medication. So when you have somebody that's geriatric, it is weird. They don't have pain like we have pain. Had a lady who had a broken femur, and we rocked the crap out of her pelvis. We checked her, we did everything, and we ended up just taking precautions because she was so old and she fell. And I'm so glad we did, because after they x-rayed her, she ended up having broken bones. And she just wanted us to get her up. But her pain was like a 2. She hardly had any, drove down our roads besides the bed being discomforting. Like, she was fine. She didn't say anything, but we went on ahead and treated her right, and her family convinced her to come in. But getting that list of medications is also extremely important when you're dealing with somebody who's geriatric. All right, so physical examination of the abdomen. We want to do an inspection. We want to see if there's any distension, discoloration, or protrusion. So you're going to look at it. You want to look at it. You want to put your hands on it to know what you have. You're going to do palpation. You're going to use your fingertips. Your painful area is last. You want to check for rigidity, pain, and guarding. So are they not wanting you to touch their left lower quadrant? You note all those things. And we need to look at it. We can't not look at it. We can't not touch it. We need to know what we have there. So vital signs, you're going to do your baseline, and then every 5 minutes, you're going to check for pulse, respiration, blood pressure, skin color, temperature and condition, a pulse ox, and a mental status, because all of that can play into effect. General abdominal distress. Some will result from digestive system disorders. Others could be cardiac or diabetic issues, food poisoning, or the flu. Assess and care for these patients with appropriate attention to airway, particularly if a patient's vomiting. Always work to calm the patient to reduce anxiety. Never give patient anything by mouth. So keep that in mind. Patient care, you're going to maintain the airway. Be prepared to suction. Administer oxygen to hypoxic patient. Maintain oxygen saturations of 94%. Place in position of comfort, left lower, or left lateral, anyways, on your right side for airway protection. Transport to appropriate facility. That's what LLR we couldn't remember last time. All right, so think about it. An 89-year-old female with a history of diabetes, hypertension, and gallstones is complaining of nausea and dizziness for about 20 minutes after eating. So we have very older lady with a history of diabetes, hypertension, and gallstones, and she's complaining of nausea and dizziness 20 minutes after eating. So what are the concerns with this patient? Is this an abdominal emergency, a diabetic emergency, or a cardiac emergency? How will you know, and what will your treatment be? So think about that, put those to play, and see where we're at. All right, chapter review. All patients with complaints of abdominal pain or distress should be transported to the hospital. These cases are difficult to diagnose without testing resources that are available at the hospital. So that's why we can't really diagnose, because it takes a lot to diagnose these. As an EMT, your responsibility is primarily to assess the patient and report your findings. Diagnosing the cause of abdominal pain, abdominal complaint in the field is often more difficult and time-consuming than diagnosing in the emergency department, where there are many more resources. Your assessment should include thorough patient history, a physical exam, and vital signs. And remember, we want to repeat those every 5 minutes. Look for signs and symptoms that can cause serious trouble. These include the sudden onset of tearing pain radiating to the back, vomiting blood or coffee-like material, the presence of black tarry stools, and signs and symptoms of shock. So if you have any of those, you need to speed it up. Emergency care will consist of protecting the patient's airway, oxygen as needed, placing the responsive patient in a position of comfort, or placing the unresponsive patient or patient with difficulty maintaining the airway in the left lateral recumbent position, that's that LLR, and transporting the patient to the hospital. Take all appropriate standard precautions and carefully clean and disinfect equipment in the ambulance, especially if the patient has vomited or had diarrhea. All right, remember, abdominal organs provide a variety of important functions to the body. The abdomen can be divided into 4 quadrants with reference to the midline and the umbilicus. Classifications of pain can help identify specific abdominal dysfunctions. Assessment and management always take a higher priority than determining the exact cause of abdominal pain. Knowledge of characteristics of specific abdominal disorders can aid differential diagnosis when assessing a patient with abdominal injury. Care for a patient with abdominal pain should include treatment of immediate life threats, administration of oxygen, placing patient in position of comfort, and appropriate transport. All right, so some questions for those of you watching the video. Think about them. What are 5 signs and symptoms of abdominal distress? Describe the difference between visceral and parietal pain. Describe a condition that may be responsible for each. And what is emergency care for a patient experiencing abdominal pain or distress? Name the 4 quadrants. How are the quadrants determined? And then our critical thinking. So you are called to a patient with abdominal pain. He describes the pain as severe and says it has been on and off for past several days, becoming severe within the last hour. So that's where we ask that. And they've answered it for us. Why are you calling us now? What additional questions would you ask the patient? And in what position would he likely be most comfortable? So that's the end of 26. We will go from there. If I can get this.